Thanks, everybody. Thanks for having me. So as Jason said, I didn't realise that I had sent my bio before I had moved over here. So I was in clinical practice. I'm an osteopath by trade, and osteopaths in Australia are not medical doctors. We study for 5 years I did a bachelor and a master's course, and we work as predominantly manual therapists, and usually in a private practice setting. So that was where I was just before we made the move to Oregon about 8 months ago. And so I'm not hands-on at the moment, which is why I'm quite happy to speak to people about their tricky cases when they email through, because it keeps my brain alive. So you might be wondering why an osteopath is standing up here today talking about cognitive behavioural therapy, and it's certainly something I've been thinking all morning. The reason I started to develop an interest in CBT and other psychological modalities in the treatment of chronic pain was driven when I started doing this Masters in Pain through Sydney University. And as you look to the literature, you get that initial crushing sense of, oh my goodness, nothing we do works particularly well for chronic pain in the manual therapy setting. But as you look across the literature, CBT as a clinical entity in the treatment of pain started to stand out because it gets often better clinical outcomes than anything comparable, perhaps about the same as what we would expect from exercise, but certainly beating most manual interventions. So I started to look into it a little bit more, read about it more. I did some courses and got a little bit of supervision and started incorporating some of the techniques into my clinical practice, and found it to be incredibly effective. So I started to talk a little bit more about it and start the discussion. So today I'm going to present an argument for why manual and exercise therapists should look towards this as a clinical entity, and what we can do about that with that knowledge, what we can do with that. So first of all, I'm going to take you through a brief literature review and a little bit about the history. So it's not going to be a comprehensive literature review, but just exposing you to some of the information. So CBT became known through the work of Aaron Beck and Albert Ellis, and it was a move away from the more traditional psychoanalytic models. And what it did was it recognised the role of thoughts and their effect on modulating emotions and behaviour as well. So CBT is an umbrella term that encompasses quite a few things, so dialectical behavioural therapy, acceptance and commitment therapy, which we're incredibly lucky to have Kevin Vowles speaking to us about tomorrow morning, and things like cognitive processing theory. And it's based on this kind of idea here, where it's the interaction between our thoughts, our emotions and our behaviour, and how if we have an influence on one area, we can make changes in that system. So we can target our intervention perhaps towards the thoughts, or and see how that affects behaviour and emotions, or alternatively we can target our interventions at behavioural approaches and see how that affects the system. So it's a collaborative approach. It's supposed to be problem solving between the client and the therapist. So it's not being dictated to by the therapist. In general, the approach is to identify unhelpful thoughts and then review those thoughts with reference to the available evidence. Now, when I say evidence, I'm not talking about a literature review. I'm talking about, does that thought, how accurate is that thought, and does that fit with this process? And can we review that thought? If we challenge that thought and it doesn't quite fit the scenario, can we replace it with a more helpful or realistic thought? So then, in the event that we can't access our thoughts, which for a lot of people might be a possibility, can we look to behaviours, and can changing behaviours influence that system? So as I said, of all the research single modality approaches, and when I say single modality, I mean things like acupuncture alone for the treatment of chronic pain, or manipulation alone, or exercise alone, that CBT probably has the largest body of evidence, so there are many, many studies there, and also displaying superior outcomes to the other modalities. As I said, perhaps except for exercise, but it's very hard to compare. You're not comparing apples against apples. So this is a brief run through about, I guess, the essence of what CBT looks like. So you could take a single situation and interpret that a variety of different ways. So if we take the situation of the person getting up in the morning and burning their toast, and the thoughts that might go along with that might be, bummer. You're not particularly concerned about that. The emotion might be a bit neither here nor there, perhaps a little bit frustrated. And the behaviour might be to cook some more toast. Or it might be to scrape the burnt toast off if you're really particularly tight. Taking the same situation and applying a different thought to it, saying, I can't even cook toast. And the emotion that might go behind that may be a bit of sadness, and it might represent perhaps depression. And the behaviour that might follow that might be to go back to bed. If we burn the toast again, and we think about that, if I miss that, what else am I going to miss? And the emotions behind that might be worry, they might be fear, they might be anxiety. And we might be constantly fussing or constantly checking things, seeing what else we might have missed in our environment. And lastly, if we burn the toast, we might think that even the toaster has got it in for me. And we might be pretty cranky about that. And the behaviour that might flow on from that might be to go and kick the cat. Very unfortunate. So you can see that that a couple of things that come from that, we can take the exact same situation and have a variety of different behaviours, but it also suggests this idea that we can potentially have an influence on those thoughts, and that we can review those thoughts that might have the influence on our behaviour. So just quickly, I am going to do this literature review. As I say, it's not going to be comprehensive, but if I just list a few things that are the limitations when we're doing sort of any literature review. We're often comparing studies where the programs vary quite differently, so we might have different staff, we might have different length of programs, different intensity, perhaps different approaches. So again, we're not always comparing apples against apples. When we're comparing to control groups, with people with chronic pain, we know that they are they're chronic patients as well, and they will always be having some kind of existing caregiver visit. So whether that's to their normal doctor or to other existing caregivers, we can't control for that particularly well. The exclusion criteria in a lot of studies often mean that they don't represent the real world patients and often what our patients might look like. So it's just interesting to note that. Obviously, with any meta-analysis, the inclusion criteria can mean that some studies are left out that might alter results. And the studies are often done in the group CBT environments. And we know, one thing we do know about cognitive behavioural therapy in the area of pain is that the patients who are more distressed and more disabled really need a more intensive program to actually get a clinical outcome, and that if you apply a less intensive program, they just won't have a response to that. So that kind of brings about that idea of matching your therapy to the client in front of you, which obviously is hard to do in a study like these. So to start with, I'll present the Cochrane review. That was the latest Cochrane review, was published in 2013. It reviewed 35 studies, and what it showed was a small to moderate positive effect on the parameters of mood, catastrophising, pain and disability. So small to moderate effect size is not going to be necessarily life-changing for these patients, but still provides hope and provides worth to look towards. This Cochrane review, compared to previous ones, found that the gains were not maintained at follow-up. And the authors noted that it was less positive than previous reviews, suggesting that perhaps there had been a reduction in perhaps the intensity or the quality of the training programs. So I'll now go on and admittedly cherry pick a few articles that are a couple of my favourites that have directed my study and my understanding of the area. This was a study that was done published in The Lancet in 2010, and it was done in the UK. So it was group cognitive behavioural treatment for low back pain, and it was a randomised controlled trial, and they also looked at the cost effectiveness. So they took 399 subacute to chronic low back pain subjects in their intervention group and compared them to 199 in their control group. They gave both groups the, I guess what you would expect, international guidelines for chronic low back pain. So stay active, avoid the bed rest, return to work as soon as you can, advice appropriate for medication. They also gave literature, which is one of the recommendations, to hand something over to the patient who has low back pain. And in this case, it was a copy of the back book. In their intervention group, what they did was 6 sessions of group CBT, and that was delivered by psychologists. And the control group were just given that advice. And then following the study, they did a cost-effective analysis. So we can see here that in the CBT group on the left side there, they looked at 2 disability scores, and what they found was a significant increase in the group CBT compared to the control group, and they considered a change above 2 to be clinically important, so that was achieved in the CBT but not the control group. And much the same in the modified von Korff disability score there. Pain scores slightly better in the CBT group, and what they interestingly found was that at 12 months the improvements were sustained for both pain and disability, but at extended follow-up it was just for disability, and that's pretty common across the studies that you tend to see. When they were looking at the cost-effective analysis, what they found that these results were similar or better to other high-quality trials of approaches that might be used in primary care, so for example using exercise approaches, but that the effects were longer lasting and broader ranging, so having more impact on people's lives. And for cost analysis, what they were finding was that to deliver that intervention, the cost was about half of any competing interventions, so ones that were getting similar clinical outcomes. So that's for a healthcare industry, that's quite important. This is a particularly cherry-picked and favourite article of mine that was done by Professor Paul Martin, who now works at Griffith University in Australia, and he's worked in the area of headaches, the psychological treatment of headaches for many, many years. And his team did this study where they took, they're small numbers but probably enough to give you an idea. So he took 51 headache subjects, 30 migraine and 21 tension type headache subjects. And in their intervention group they had 8 one-hour sessions that were one-on-one, so fairly intensive in terms of cost and resources. So you can see in their groups they had 20, 19 and 12 in their groups. So the CB2 group was that one-on-one. The biofeedback group all did relaxation training, and it was with reference to the temporal pulse amplitude. That was the bio bit that they used as feedback. But they also had the same amount of therapy, so it was about 8 hours, and the control having nothing there. So a 68% reduction in frequency and severity of headaches in the CBT group compared to the 55% in the biofeedback group, which is also quite good. That continued to improve over 12 months, and I guess that would be the idea of CBT, is learning those life skills where you can, become more resilient over time and challenge those thoughts, compared to the biofeedback group, which remained pretty stable. And then, really significant drops in medication use there, 43%. And you can imagine that the side effects of those particular types of medications, that's quite significant. Another study I found quite interesting also came out of the UK, and this was published in Physiotherapy in 2008. And I guess I like this one because it does sort of has clinical implications for us. So what they did was they took physiotherapists in an NHS hospital and train them up in cognitive behavioural approach. So not training them to be psychologists and to use cognitive behavioural therapy, but to take the essence of that and merge it into their practice and use it for all components of their practice. So they did it for chronic low back pain patients, and what they were looking to see was were there changes in cognitive factors, and did those factors have an impact on disability and pain scores and other outcomes? So if they had an impact on those cognitive processes, were they going to see changes in pain, disability and depression? So they had 137 people. It wasn't a controlled study, so it was really just looking at the effectiveness of this particular intervention. Small groups of 7 to 2 physiotherapists and quite a few sessions, so 5 3.5-hour sessions over a 6-week period. And as I say, the cognitive behavioural approach was infused through their program, so using the exercise, the education, the goal setting and the problem solving. What they found was significant reductions in disability, in fear of movement and re-injury, in catastrophising and depression. Increases in self-efficacy, perceptions in control over pain and perceptions in the ability to decrease pain. And quite small changes to pain scores, which we fairly classically see in a lot of these studies. They listed it as being a small to moderate effect size. So I think with reference to that literature and with reference to the idea of cognitive behavioural therapy, as an osteopath and as a manual therapist, I see that this gives us 2 really important ways forward in recognising that efficacy. So, and those 2 ways, I believe, are, firstly, that can we as clinicians who are working with patients in pain, can we look to these methods and learn about them and perhaps upskill with a focus on communication? So not with the intention of learning this and changing our scope of practice and becoming psychologists, but can we integrate these techniques into our practice on a day-to-day basis? And then the second way forward that I think is really important as well is in recognising that psychologists are good at this. Can we look to getting psychologists on board as part of our team far more often, as a matter of course? And I know that even in saying that a lot of you are thinking, yeah, that's great, but, and this is the but, and I think she sums up this quite beautifully. This goes for 2 minutes.
See that kind of severe...
And it was like, not only was it the colour and all, it was hard. It was like rock hard.
How did friends react to this?
She has CRPS.
Oh, friends are
in her
full
arm.
of useful advice. Some friends are full of useful advice. They say things like, have you tried acupuncture? Have you tried, whatever, hypnotherapy, all of that. And yes, you do try all of those alternate sort of things. After the spinal cord stimulator made the pain worse, I said to the doctor, the pain specialist, just turn it off, just leave it there. And he said, I think you should see a psychologist. Well, I went home in tears. I said to Terry, he thinks I'm mad. Seeing the psychologist was probably the single best intervention that I did.
Why?
She taught me that I wasn't going mad in the first place, because sometimes I used to think I was going crazy. Sometimes I'd look at my hand and think, oh, that's not my hand. That's not my arm.
This is the disconnect.
That's not my leg. She taught me how to deal with all of that, and she also taught me about mindfulness.
What's mindfulness for people who don't know?
My layman's definition of it is what it is. I have got pain and I have to live with that pain, and you just connect with that pain.
So did that mindfulness decrease the pain or alleviate the pain for you? Did it help?
It helped. It helped. The pain, it helped me cope with the pain, I guess. And then through talking it through with my pain specialist, and I was on lots of narcotics and opiates, we decided that wasn't the way to go, so I've stopped all that, and I'm going back to a rehab program, and yeah.
So what are you doing now? When you feel that pain, what do you do?
Well, once upon a time I would panic. I don't panic anymore. It is what it is. Okay, this is bad. Is it because I've done too much? If it's not that I've done too much, I must be having a bad pain day, a bad flare. And you just move through it. And instead of not doing anything, maybe just do a little bit. Might go for 4 or 5 days where I don't sleep because of the pain. And again, use the mindfulness, it is what it is.
I don't want...
I thought she summed up that but that I was talking out quite beautifully. So he thinks I'm mad. And that is always the concern when we're thinking about making a referral to a psychologist is, are we giving the patient the impression that we don't think that their pain is real, we think they're mad, we think they're crazy, we think it's all in their head, or we can't help them. Now, the techniques that she's talking about are probably more in the ACT realm, which I am going to dob Kevin in to define for us tomorrow and delineate the differences between the two different approaches, but they are, I guess they do come under the same umbrella. So he thinks I'm mad. Then she says, seeing the psychologist was the single best intervention that I did. And I think that sometimes we can look to this and take away from this information the idea that sometimes our number one therapy goal can be to make an effective referral to a psychologist, and that is a noble therapy goal to have, to help them over that hurdle, essentially, and create that team around the patient. It doesn't mean you have to excuse yourself from the picture, but perhaps just beginning to create that team around the patient. So as I said, using the techniques, perhaps the element and the structure of techniques like CBT to improve our communication, and we'd probably call it a cognitive behavioural approach. And Bronnie just said this just before I got up here. She said, I always say you're doing it already. And I said, shut up, that's what I'm going to say. You're doing it already. We have these conversations with our patients every day. We challenge their thoughts, their understanding about their condition. What I would suggest is that we perhaps just perhaps make it a little bit more formal. So that might mean sitting a bit more and sitting with our patients, to perhaps give it a little bit more structure. And the beauty of something like CBT is that it does have a level of structure that you can look towards to structure these conversations, because they are often quite difficult conversations to be having. As soon as I started doing this in my practice, the number of times that I would run over time and have tears in the session just went through the roof, and luckily I had understanding receptionists. But really, you just need to perhaps give it a bit more emphasis and a bit more weight and a bit more value. And that's, again, if we can reflect on the literature and says this works and that this has value, then we're probably more likely to trust ourselves to sit on our bums and value that time spent talking with the patient rather than rushing to hands-on. So this is how I kind of interpret it. I think these little... The CBT there is the essence of CBT, the aroma coming off the coffee there. And I think the idea is to bring it under the umbrella of pain education, because that is well and truly within our scope. And again, we are already doing that. So I would suggest that bringing these techniques under the umbrella of pain education is the way we might view this, so that we, particularly if we're worried about stepping outside of our scope. So in just mentioning scope briefly, it is obviously where there is likely to be a bit of pushback and potential for issues to arise. And I think some of the guiding things that can help with that is to perhaps keep that idea of bringing the essence of it under the umbrella of pain education, which is within our scope. And within that you might be sticking to discussions about pain and discussions about the person's condition. So if the person is talking about conflict with a partner, or conflict in the workplace, or generalized anxiety disorder, then we know that is not within our scope, and that's probably not where we should be going. But certainly discussions around pain, we're already doing that, so formalising that is probably really good. And our duty of care exists regardless of whether we want to be having more of these discussions or not. That if psychological comorbidities exist and you feel that they are significant, or that the patient is potentially unsafe, that we need to be making those referrals anyway. So if there is, potential for suicide or self-harm, we need to know how to ask those questions, and then have the referral systems to know essentially what we would do in the case that the person did respond that they were in a situation like that. And again, that's regardless of whether we are having these discussions or not. That's part of our duty of care in looking after the patients. So in improving our communication, the ways that we can go about that are potentially to identify the resources that might help us to upskill in that area. So that might be doing a bit more reading, it might be taking some courses, and there are some courses. I've got some resources at the end of this talk that you might be able to look towards to learn more about this, that are pitched towards allied health professionals. You might look towards someone who might be doing some supervision for you or having discussions around this area, and really put that emphasis on improving communication, so with reference to that approach. And then I think the other thing is to start the conversation. So there is this fear of scope and this idea that we need to be walking on eggshells and being careful about this, but I think we need to start the conversation and be having the discussions more if we're to venture into these areas. And I like Kevin's approach to it. He says this is not psychology, it's human behaviour. This is just an example of a structured way that you might use in your clinic, and I'm not going to teach how to do this, but it takes, it's called a thought record sheet, and you can download tools like this off the internet. So on the left there you might list the situation, so it might be burnt toast. And then you might be able to label the emotions if you can. You might be talking the patient through this, the physical sensations that go along with that let the patient know that they are feeling distressed or whatever those emotions are. And then if they can, to be able to spit out that unhelpful thought and work through what the thoughts are. And there's some really nice prompts at the bottom of these. It hasn't come out very well. What went through my mind? What buttons is this pushing for me? Prompting thoughts, really open-ended questions that can draw out those thoughts. And then the part that's probably integral to the technique is to assess those thoughts and assess the accuracy of those. So are there alternatives that you can come up with? Is this fact or is it opinion? What might someone else say about this? Sometimes it can be helpful to say, look, what is the worst case scenario? And if that happened, what might you do? And even sometimes working through that scenario can be helpful for people because they realise it's actually not as bad as they had thought. And then, can you replace that with something that's more helpful or more aligned with the real deal? And so you could be doing this either formally, so if you're really feeling comfortable and happy to sit with the patient and hand the pen over to them and get them to work through a worksheet like this, or you could take the structure of it and do it while the patient was doing their exercises or while they're on the table and you're doing your treatment. So formal or informal, and I think we have a really good opportunity to be doing these kinds of approaches because we have longer consults, we have the touch which helps with the rapport. I think they are really good and ideal for us. That second way forward would be to look towards increasing the number of referrals we make to psychologists. Sorry, my font there has gone a bit small. And really improve the chances of that referral sticking, so the patient actually going through with your suggestion to go and see a psychologist as part of creating that team. So, and I think there are some techniques that we can use in how we make that referral to help that process along. So I think one of the first things is to make sure that you have a really good rapport with the patient and that you have spent plenty of time in your pain education or your history taking imparting the idea to the patient that you believe their story, you believe their pain is real, you really understand, you empathise with what they've been going through. And for that to be strong enough, it may mean that you don't make that referral on the first consult, that you may wait down the track until you have a stronger rapport with the patient and you feel that there is that trust. I often use the idea when I'm delivering pain education that because our thoughts and can drive a lot of these processes, and our worries and our fears and perhaps not understanding our condition can drive the process from an acute to a chronic phase, and I'll be drawing this with pictures, that I can give that a level of tangibility so that I can then draw onto my picture that if we can address these thoughts here, and I might be outlining areas of the brain that I'm talking about, and we can reduce the fear and the worry or the activation of these particular areas of the brain, then that can be helpful in backing off the whole process. So I'm giving it an element of physiological tangibility so that it's not again, I'm not dismissing them, I'm not just sending them off because I think they're crazy. Having your psychologist in-house can be incredibly helpful. So what that does is it just increases the familiarity of the scene for the patient, so they're not having to find somewhere and go out of their comfort zone. It helps with the transition in making the appointment, so you might be able to just send them straight out and out to the receptionist. And overall just helps to make that stick. So it might mean that you touch base with therapists who are in your area and perhaps offer them a room or look to collaborate with them. In the event that you can't do that and that's not possible, then making the most direct referral and the most personal referral that you possibly can. So that means reaching out to psychologists in your area, knowing how they practice so that you can be sure that they are sort of practicing along the lines that you might and have these intentions in mind, these similar ways of practicing in mind. And having those referral systems in place. So again, so that you can reassure the patient that you know this person, that they are trustworthy, that they have done well with other people in the past, and that the personal nature of that referral is there. And then part of that as well to normalise psychology. So it is often for a lot of people it's seen as just being something that's quite frightening and confronting, and so just normalising. So say that we do this kind of stuff on a day-to-day basis. I work with this person very frequently. A lot of my patients see this person. We've had good success for people framing it as being sports psychologists. You're going to see the sports psychologist. Or the pain psychologist as well. I mean, the lady I worked with had many years of experience in the pain clinic, so we just called her a pain psychologist, and that seemed to help a lot. And part of that is not necessarily just creating that team with a psychologist, but looking to other modalities as well. And for every practitioner that we get on board, the literature tells us that we're going to get slightly better outcomes. So we can see ourselves perhaps as a case manager in creating a team and facilitating communication between that team, because the difference between having a whole lot of individuals working with a patient and having a multidisciplinary team is the communication between those practitioners and making sure that they're all aligned in the same direction. And that can also make the patient feel like you've got their back, that you're creating this team around them and you're all working together. In order to do that, again, you have to have the referral base existing. So you have to have reached out to those practitioners prior to the patient walking in the door. I've popped these in, you've probably seen them, but they're a couple of my favourites, and I just thought I'd show them quickly. The title of this one tells it all. So the therapeutic alliance between clinicians and patients predicts outcome in chronic low back pain. So that pretty much says it all. But when we break it down and have a look at it, they took 182 subjects, and what they found was that when they measured the alliance, so the strength of the therapeutic relationship between the patient and the physical therapist in this instance, that the level of that alliance predicted all the outcomes that they measured, all 8 outcomes. So including disability, global perceived effective treatment, pain, and ultimately function is really what we're looking at there. And then a meta-analysis that was done, a systematic review that was done just a little bit prior to that, which says very much the same thing. So positive associations between therapeutic alliance and treatment adherence, improving depressive symptoms, treatment satisfaction, and again, function. So I think being able to refer to this knowledge base and this understanding can give us a lot of power when we work in this very action-based occupation. So we're often, and the patients often see our value and our worth in what we do with our hands or what we do with our exercises. And so for us to think about sitting on our bums as being therapeutic can sometimes be quite confronting. And when I talk about this in Australia, it's quite a different response, and people can see themselves in this setting or can see themselves backing themselves and sitting. One of the questions that I often get asked in America straight up is, how do you bill for it? And so I think that is something I don't have a lot of experience with, and something that you probably as a profession need to discuss amongst yourselves. But I really believe that bringing that under the umbrella of the pain education is part of our job, and education is definitely part of our job. So I think, you know, a lot of those ideas, we're doing it already. Back yourself and go for it, safe in the knowledge that what you are doing has value. It has value and it has merit. So it brings up this kind of idea for me. So this idea that in creating a team and creating a multimodal treatment approach, that you set the foundations with all of these elements. So you're creating the foundations there, and that the time that you spend listening to the patient is feeding into this. But a lot of it just comes down to time. It comes down to touch. It comes down to listening. It comes down to making sure that you can demonstrate to the patient that you've understood their story. On top of that, you would then lay further foundations, so probably a diagnosis and a plan that everyone agrees on and that the patient's involved with. You might infuse the whole thing with cognitive behavioural approach and pain education, obviously, as a solid platform for going forward. You then look to your box of tricks, and here I'm going to duck so that Jason Silvernail doesn't throw his shoe at me. This is not a toolbox, Jason. This is a box of tricks, which is quite a different thing. And in a box of tricks, you can have a variety of different people. So you look to your box of tricks, you've got your foundations, and then you build a treatment approach that's appropriate for that individual. So for this person, it might look something like this. It might look like you would include exercise, perhaps a medication review, a medication trial. You might get someone to stop a particular medication. Relaxation training might be part of that, and perhaps manual therapy. And they might be 4 different practitioners that are adding to those interventions that you have created as the case manager, I guess, in those foundations. For another person, it might look like this. So you might think that exercise will lead the way as being a really important component, but then they need to tap into some of the stuff that they've lost in having chronic pain and tap into that values-based approach, so getting them back to doing fun stuff. Or, in some cases, you might recognise that those psychological comorbidities are playing such a defining role in this patient's pain experience that your number one therapy goal is to create an effective referral to a psychologist. And again, as I said, that doesn't necessarily mean you have to withdraw from care, but it just means that your priority is to establish that relationship so that it's strong enough that you can make that referral effectively. So just a couple of resources to finish up there. That CBT worksheet that I showed you is at that particular website there, Get Self-Help. It has lots and lots of free resources that you can download and read. For courses, one of the ones that I did was by the Australian Psychological Society. It's an online web-based course. It's got about 10 hours of content with lots of videos, and it costs about 480 Australian dollars, which is about $2 US. There are other online courses. I believe there are some through the American Psychological Association. Is that what they're called? There will be equivalents in the US that you'll be able to find, and often they are pitched at allied health professionals. If you look to the UK, this has been established, and they're talking about this and integrating it a lot better than other countries. So they have a lot of resources as well. Bronnie Thompson has some fantastic CBT resources on her website. That's what's your website, Bronnie? Health Skills blog. Sydney University has a webinar course which actually requires you to be online for their 8 sessions. I think they're 8 one-hour sessions, and again that costs about $3 US there, but incredibly high quality and tailored really for the multidisciplinary approach. That's a fantastic book that is a workbook that Rajam has copies of for us if you want to have a look at that. And I forget what that last link was. And that's me if you want to have a look at my website or some of the blogs that I do. And that's it. Thanks, Stacey.
All right, so we've got about 15 minutes or so for another Q&A session. There's a number of questions I would personally like to ask, but we're going to see about taking some questions. We have a microphone. You have the microphone in back there? Okay, great. Any hands for questions? Okay, I saw a question right there in the back.
Hi, Alison. Great job. Carolyn Van Dyken from Canada. You did really well under the pressure of heat, you poor thing. I really love how you correlated using CBT under the pain education umbrella. And when you talked about starting the discussion, I think one piece that I missed that I think needs to happen more in physiotherapy practice at least, is to start using more objective measures to measure the psychosocial distress. So depression, anxiety, stress scale, pain catastrophizing scale, TSK, and that will help us to then start to identify those folks that perhaps we should be doing more of a CBT approach with. I just want to comment on whether or not you use those regularly. And
I do. Towards the end, I started out just doing fairly general practice when I moved back to Melbourne, and we were there for 2 years. And the longer I stayed there, the more and more chronic pain patients I started to see, and the more objective measures we started to use as a clinic because we set it up as a pain program. My favourite is the PCS, the pain catastrophizing scale. I like it particularly because then you can pick ones that they've marked fairly high and perhaps discuss them with the patient. So they might have said, "I'm never going to get any better," or and you might pull that out and say, "So what makes you think that?" And what. So yes, I do use some objective measures, and probably should have been using more.
Great, thank you. Another question. So one of the questions that I had for you is that the cognitive behavioral therapy that you have been talking about, it sounds like it's a more extensive approach, whereas somebody comes for a therapist, how would you present that? If somebody comes in expecting to I'm just here to do my physical therapy, I'm just here to get a massage, or whatever the manual therapy may be.
So I think setting the patient's expectations is obviously the most important thing. It's much easier if you can do that before they walk in the door. So for us, when we were running this as a pain program, we had brochures that said you will be doing a lot of talking, you'll be doing a lot of exercising, and making that quite a defined program so that they couldn't opt out of the exercise and they couldn't opt out of the talking and the education bits. That definitely helped. As soon as we started doing that and patients were coming in knowing that was going to happen, we had far less refusers, I guess. As for if they're coming in and you're suggesting that this could be a way forward, well, firstly, I don't think you necessarily need to do it formally. So you don't necessarily even have to let the patient know that that's what you're doing, particularly if you're integrating it into your table-based work or your exercises as a discussion while you're doing that. But then if you felt that you could get more out of it by sitting, then I think just having that dialogue with the patient. And initially, when I started doing this, I was quite timid, particularly about charging full price. You obviously usually have to do extended sessions. Instead of doing half an hour, I'd tend to do an hour because they obviously take a little bit longer. But to be sitting or to be hands-off, to back yourself to do that was quite tricky. And I'd always be worried that the patient would think that they weren't getting value for money or that they would be resentful of that. But then the proof was in the pudding for them, so that they could see that often that was the session that turned things completely around for them, and they could really see value in that. Or you often really cut to the heart of their problem, and again they could see what the purpose of that was for. And then I got more confident with it, and because it became our thing that we would do this and we would do this and we would do this, and then you do your exercise, by the end of that sort of process I had no qualms in charging full price for often doing education-based sessions that sort of involved a CBT approach. Yeah.
We had another question coming in from the internet.
We have a question from Taylor S., who is following online right now. She says, similar to orthorexia, is there a concern for a patient developing an obsession with thinking thoughts that one considers healthy?
So, positive thinking is the only way forward, I guess. I don't know. You'd have to ask the psychologist about that. I'm just an osteopath.
We have another question from this gentleman here. That was the most concise answer I've heard all day.
Do you know if the Cochrane review did a subgroup analysis for specific types of pain?
They don't, as far as I'm aware. They have acute pain ones, and usually the headaches are excluded. But I haven't come across any that subtype.
So, is there any evidence to suggest, or just from your clinical experience, that CBT works particularly better for specific types of pain?
I think it's probably more about that it works better for particular patients. So if you are recognising that a particular patient has higher yellow flags, so those psychosocial factors that are risk factors for developing chronic pain, or if you recognise just on clinical interview that they are prone to catastrophising and that they're worrying about their condition, that I think that's probably more of a clinical indicator of the type of patients that could do with that kind of approach, compared to some who are quite pragmatic and I guess that is the biopsychosocial discussion is how much of this individual emphasis do we put in what area. So I think rather than looking at the pain or the pain types, I think it's probably more the personality and the person and how they view their pain.
So these traits can be distributed across different pain categories, in other words?
That's what the Cochrane reviews tend to do, yeah. Okay. So they're across most categories.
Thank you.
Yeah.
So another quick question for you.
Yeah.
Could you speak to how you might employ cognitive behavioral therapy with someone that has difficulty verbalizing what's going on inside?
Yes. With great difficulty. In that case, then I did have to, and I'm thinking of one particular patient who comes to mind. He was a 19-year-old boy who had chronic low back pain. You'd look at him, he was very tall and very fit and quite healthy. He was at university but was completely disabled by his pain. He'd been playing AFL football but hadn't run for 2.5 years with this low back pain and was just really worried and had multiple failed treatments, so it was quite a sad case. But and I worked really hard to establish a rapport with him, and he was like a 19-year-old going on 15. He just grunted, and you could not get anything out of him. So for me to try and access his thoughts, it was just the most useless process. Eventually, after about 5 or 6 consults with him, I managed to draw some thoughts out of him to the effect that he was quite miserable and that he was quite depressed. But it really did take that long, and that was, the explosion of words that I got from him was about 2 sentences to hint that. And I'd already been we created a team around him, so I'd been working with a sports doctor, and in the end I rang the sports doctor and said, look, I think this kid's quite miserable, and I think that's underpinning a lot of his clinical outcomes, and I think he needs to go and see a psychologist. And he said, I think the same thing, and I'd already suggested it to him, and he said flat out no. But when the doctor suggested it and when he pitched it as being a sports psychologist, the kid went along with it, and it was 2 sessions with her, and he started to do a lot better. And now, a week ago, I got an email from the practitioner that I had referred him onto when I left, saying that he's doing a pre-season for footy training, so he's doing brilliantly. He probably still grunts and doesn't, there's probably not a lot of acknowledgement about the fact that he's doing really well, but, yes, it is. And so in those cases, you probably just have to recognise that is outside your scope and that someone might be able to do it better. But again, making that referral can be such a massive hurdle. You sometimes have to be really creative about how you do that. Yeah.
Sorry, I thought I saw a hand pop up there. So one other question would be, when employing CBT, and if you find that the patient you're working with keeps bringing in things, he wants to address all kinds of stuff other than pain.
Yeah.
And you need to stay within your scope.
Yeah.
How do you manage to continue to use CBT and stay on? I mean, like, how do you manage the patient that wants to constantly drag you into other areas?
Well, so probably much the same way if you weren't exposed to using CBT techniques. You reference it to your scope and how much you're prepared to give out to your patients and where you want to go in that relationship with the patient. But I guess even then, if someone wants to have a chat to you about their relationship and you would have done that under ordinary circumstances because you're close to the patient and you know them, you've got history with them, I guess then again just looking to the structure of it, so asking those open-ended questions and then perhaps helping them to review the thoughts if they are able to spit them out around that and help them to challenge the thoughts. So you're not doing it for them or telling them that their thoughts are stupid and that this is probably a better thought. You're really getting them to do the work and to examine it themselves. Yeah. So yeah, I think it really depends what you're prepared to give over, and I don't think knowing about CBT would change that a lot.
At what point would you refer out?
I think when I go back to Australia and set up my super duper pain clinic, I would probably have a psychologist on staff, and I would probably make sure that every patient that came in the door had contact with a psychologist or other members of the team who are trained in CBT approaches. I just think it's too good to miss. I really do. So yeah, I think your threshold should be a lot lower for referral, knowing that it works.
Fantastic.
Yeah.
Do we have any last questions? We've just got another minute or two. All right. Then, in that case, please show your appreciation. Thank you very much.